Dr. Kim is a well-known colleague from South Korea. He is in Seoul. He's the director of vestibular laboratory and neurology department in university in South Korea in Seoul in Bundang. And he is one of the foremost experts in vestibular system, central vestibular system, and his forte is cerebellar nystagmus, particularly the central positional nystagmus. So without any delay, we will start Dr. Kim. Unfortunately, because of the way the lectures are, it is beyond midnight in Korea, so Dr. Kim won't be able to join us in the panel discussion, but if you have any questions, we will be happy to answer the best we can. Otherwise, we will forward it to Dr. Kim and we will get back to you. We can start, please.
Hello, everyone. Thank the organizer for inviting me, and sorry for conveying this lecture on central positional nystagmus online. As you know, the central positional nystagmus is not so common as PPPV and mostly can be differentiated from PPPV based on the associated symptom and signs of central origin. Occasionally, however, the differentiation is not so easy, and especially when dizziness and imbalance are the only or the main symptoms. And this talk would be mostly on the clinical features and the recently proposed mechanisms of central positional nystagmus. Okay, let's start with this 72-year-old man who presented with dizziness and imbalance for 2 years. And he had the diagnosis of epigeotropic horizontal canal BPPV several times by the ENT doctors, but there were no response to repeated canalus repositioning therapies. And he also had a brain MRI twice, which had been reported to be normal. And there had been aggravation of the symptoms over the year before the visit to my clinic. And indeed, at the time, he should use a cane for walking when he entered my clinic. And sorry, this is the recording of nystagmus and no nystagmus during visual fixation. And when the fixation was removed, you can see this small or left beating nystagmus, and there's right beating nystagmus on head turning to the left, Y supine, and this left beating nystagmus during head turning to the right. So there was the epigeotropic positional nystagmus during supine head-roll test. But the findings of the audiovascular evaluation were all normal except the rightward SVV tilt. And at the time, he didn't bring his previous MRI, so I asked him to do next time. And these are the MRIs he brought. And there are no gadolinium contrast images, but on this MRI, do you see any abnormalities in the brain here? It may appear normal, but if you focus on the midline cerebellum, here you can see these fuzzy signals here where the cerebellar nodulus is located. So since there was no gadolinium enhancement in the previous MRI, so I repeat MRIs with a gadolinium enhancement, and the imaging now clearly show this ring enhanced lesion in the area of cerebellar nodulus, and further workups disclosed the pulmonary tuberculosis here, and with the anti-tuberculous medication, he showed the gradual improvement of the symptoms, dizziness, and imbalance, and finally he became symptom-free along with near complete resolution of the previous lesion. So what are the lessons from this case? So this case clearly shows that CPN may mimic benign paroxysmal positional vertigo. So you should be very careful when positional nystagmus does not respond to repeated cannulus repositioning therapies. And when you order the MRIs, you need to indicate the requirement for the gadolinium enhancement. And once the MRI is obtained, you should focus on the areas around the fourth ventricle to detect small lesions. And this central positional nystagmus may be a finding in patients with acute vertigo. Likewise, in this patient, and in this case, provide further difficulties for differentiation from BPPB, especially when the nystagmus is paroxysmal. And in this patient, you can see this paroxysmal vigorous downbeat nystagmus on lying down. And there is reversal of the downbeat nystagmus, upbeat nystagmus on resuming the sitting position. So this pattern of nystagmus may mimic the BPPB involving the anterior semicircular canal. And the patient also showed this right beating nystagmus and turning the head to the left. So apogeotropic nystagmus, persistent, and then this left beating nystagmus on turning the head to the right. So the patterns are apogeotropic type of benign paroxysmal positional vertigo, but the patient reported severe imbalance along with mild headaches. So we proceed to MRIs because there is no response to repositioning maneuvers, and this MRI shows this discrete acute infarction involving the cerebellar nodulus. So the central positional nystagmus may be either paroxysmal or persistent, and there may be no change in the direction of nystagmus, but more commonly, the direction may change according to the positional maneuvers. And more commonly, both the paroxysmal and persistent forms of positional nystagmus coexist in a single patient, commonly in various directions. And these are the examples of recording of central positional nystagmus. In the upper panel, you can see this paroxysmal positional nystagmus. In this case, downbeat nystagmus during straight head hanging. And in case of paroxysmal CPN, the nystagmus is usually maximal at onset, but there may be a latency or build-up over a few seconds, and then the nystagmus dissipates over the following 10 to 20 seconds. And if you look at the panel below, even in the persistent nystagmus, if you closely analyze the recordings, you can see this paroxysmal component during the initial portions in the initial portion. So more often the central positional nystagmus takes the form of combined paroxysmal and persistent nystagmus, likewise in this case. So these are the characteristics of central paroxysmal positional nystagmus. So the nystagmus occurs mostly in the direction of head motion. So mostly downbeat nystagmus during lying down or straight head hanging, and upbeat nystagmus on resuming the sitting position, and the horizontal geotropic or apogeotropic nystagmus during supine head roll test. And the direction of nystagmus is mostly aligned with the vector sum of the canals inhibited during the positioning. So when we analyze of the nystagmus using the mostly downbeat nystagmus during straight head hanging, but there are all the vertical, torsional, and horizontal components when you induce the central positional nystagmus during these half-pike maneuvers. And as I showed before, the nystagmus is mostly maximum peak at its onset, and then the nystagmus decrease with the time constant of canals affected during the positioning. So nystagmus mostly disappears within 10 to 20 seconds. Here you can see these patterns of nystagmus, and the time constant of vertical nystagmus is mostly at about 3 to 5 seconds. And if you look at the direction patterns of nystagmus, CPM mostly showed combined persistent downbeat nystagmus during straight head hanging and apogeotropic nystagmus during supine head roll test. And if these patterns of CPPN, paroxysmal central positional nystagmus, is observed from the localized lesions, you can frequently found that the lesion mostly involved the cerebellar nodulus and uvula. So when we did an overlap analysis of the focal lesions responsible for CPPN, we found that the overlap is mostly in the cerebellar and nodulus. Then, how does this type of paroxysmal nystagmus develop in central lesions? So, during the head motion, as you know, the rotational cue generated from the canals and the gravito-inertial acceleration signals from the otolithic organs are processed through the tilt estimate circuit in the brainstem and cerebellum to estimate the head motion and gravity direction. So if we pick up the signals from the vestibular nerve during the positioning, you can see this acceleratory signal followed by small rebound. So in case of straight head hanging, there would be an initial excitation of the posterior canal followed by a small inhibitory rebound. So since the nodulus and uvula normally inhibit the irregular vestibular afferents, lesions involving these structures would disinhibit this signal and result in prominent post-acceleratory secondary phenomenon, which cannot be corrected by the rotational feedback, and the remnant signal would generate nystagmus with the time constant of the involved canal. And this is just a postulation, and for detailed characteristics and explanation, please refer to this article published in Neurology in 2015. So if the proposed mechanism is correct, then we assume that the nystagmus should show the characteristics comparable with this explanation. So most of all, then the CPPN should occur in the planes of the semicircular canals affected during the positioning, as I showed before, and then the intensity of nystagmus should depend on the positioning velocity. So if you look at the videos here, you can see this prominent downbeat nystagmus during positioning at normal speed. But if you position the patient at a very slow velocity, you can only see this very small nystagmus, even though the final position of the head was same. And with this study, using the motorized chair, so at the velocity of 10 degrees per second, the positioning to this only the small downbeat nystagmus. But the rotation velocity was higher at 40 degrees per second. You can see these figures, so downbeat nystagmus. So you can see this build-up of CPPN along with increase in the positioning velocity on this recording. So thus, in a strict sense, this is positioning nystagmus, not a positional nystagmus. And also you can refer to this article published recently for the characteristics of CPPN during at different positioning velocities. And if the nystagmus is generated from the disinhibition by the lesions involving the cerebellar nodulus and uvula, the nystagmus should be or maybe inhibited by baclofen, is the inhibitory neurotransmitter used by the nodulus and uvula when they inhibit the vascular nucleus. And this is the finding mentioned was on baclofen 10 milligram 3 times a day, and you see this downbeat nystagmus here, small, but after discontinuation of the medication, the baclofen, we observed this more vigorous nystagmus, downbeat nystagmus during straight head hanging. So we believe that the baclofen may have some effect on the central paroxysmal positional nystagmus, and now we are performing the controlled trial with this medication. In contrast to the paroxysmal CPN, the CPN may be persistent, and there may be no change in the direction of nystagmus, in this case persistent downbeat nystagmus during head bending, during spine and prone position. This was observed in a patient with lymphoma involving this fourth ventricular area, mostly on the left side. And we also did the lesion overlap studies in this patient with persistent form of positional nystagmus. And again, the lesions are overlapped in the nodulus, which explains the frequent coexistence of both the paroxysmal and persistent forms of nystagmus in a single patient. Then what is the mechanism of this persistent form of central positional nystagmus? You know, the oris organs provide information on the gravito-inertial acceleration, but they cannot discriminate the head tilt from head translation. And it is the velocity storage mechanism that enables our brain to discriminate between these signals, head tilt and head translation. And when the function of this tilt estimation is disrupted, by a lesion involving the nodulus and uvula, or the pathways that provide these signals to the brainstem, and there is a bias in the estimated gravity direction. The compensatory rotational feedback would generate this constant nystagmus. And again, please refer to this article for more detailed explanation. It published in 2018 in Brain. So, how can you diagnose that central positional nystagmus? It's very rare, and report it was stated that it comprised about only 2% of all positional nystagmus, and you should suspect CPN, and the patients showed atypical features of dizziness. So sometimes the intense positional nystagmus, but little or no or vertigo in association with this positional nystagmus. And in case of central lesion, this positional nystagmus occurs in multiple planes. So vertical nystagmus during straight head hanging, horizontal nystagmus during head turning, Y spine. And in central positional nystagmus, especially when paroxysmal, the intensity is typically at its peak initially, and then the nystagmus decrease exponentially over time, rather than the gradual build-up patterns over 10 to 20 seconds in horizontal cupule lysis. And we can find the associated central symptom signs, including severe imbalance and other cerebellar signs, and we can confirm the circumscribed lesion on MRI or cerebellar atrophy that may generate CPN2. But you should be very careful, because the patterns of nystagmus may mimic BPPV, because the features, there's some overlap, and MRIs are not always abnormal. So when the atrophy is subtle, you cannot tell whether it is abnormal or normal, and sometimes even the normal individuals can show some degree of positional nystagmus. So central positional nystagmus is, in a sense, is a diagnosis of exclusion. You always think about patients when you see this type of nystagmus in a patient with dizziness. How can you treat the central positional nystagmus? And it is most important to find out the underlying pathology, especially when it is treatable. And if it is from the degenerative condition, or when the patients report severe symptoms with the nystagmus, you can try the baclofen, clonazepam, and also the gabapentin and 4-aminopyridine, even though the evidence is not so concrete. So to summarize, you should always suspect the possibility of central positional nystagmus when the patients present with atypical features, and the patterns of positional nystagmus was not consistent with the BPPV, and when there is no response to repeated cannulus lead positioning therapies. And please remember that when you order the MRI, you should indicate the requirement of gadolinium enhancement, and you should focus on the peripostventricular area to detect a subtle lesion. And thank you for your attention. And finally, I also would like to express my appreciation to my colleagues in our hospital, and Glasgow doctor, Professor Glasgow, and Dr. Ji for the helpful comments for building up the mechanism for this central positional nystagmus. Thank you.
So Dr. Kim is not here, but there are some questions that we will try to answer ourselves. Maybe we can share it amongst the colleagues. The first question I'm happy to answer that is baclofen only helpful in uvula/nodulus lesion? Is it harmful in giving other central lesions? So correct me, or if you guys have a different input, let me know, or you can add in, but typically we use baclofen in treatment of several other forms of nystagmus, not just related to nodulus or uvula, but the experience is that it works out very well for the nystagmus that comes from nodulus uvula, such as periodic alternating nystagmus is one of the classic examples. And there are many other medications that we end up trying for other forms of central nystagmus. But baclofen in general is very safe medication. It can be used without causing any harm, so to speak, to our patients. So you can always try in other central lesions if you don't have any other option. The second question is from Professor Zuma. The question is, excellent presentation, congratulations. I have one question. Is there any difference between the nystagmus in sitting and supine position between central lesion and BPPV? Since this is central versus peripheral, anybody else wants to take it? Jorge? Or anybody else? I can answer that. Would you like to answer that, or I can answer it?
What was the question?
The question is there a difference of nystagmus in sitting versus supine position between central lesion and BPPV? So basically position change in the nystagmus from sitting to supine. How would you differentiate that for the central lesion and the BPPV?
I don't know if you can really say that you can differentiate. Often you have a downbeat nystagmus in the hanging head straight position, and then you can reverse in the sitting position. Sometimes you can actually see this nystagmus without the goggles, and actually it's enhanced by fixation, which I find also frequently helpful. If it's enhanced by fixation versus only present with fixation block. And just as Dr. Kim suggested, the association of cupulolithasis pattern, horizontal, and downbeat nystagmus with the head straight is very suggestive. So when you want to differentiate the two, peripheral cupulolithasis versus a central lesion, the association with the downbeat nystagmus is really helpful. And the last point that he made with the prone position, we couldn't do that before, but now with the goggles it's real easy. You also see downbeat nystagmus with the prone position. The vesiculospinal correlate is truncal ataxia. They cannot do tandem gait well. So that combination, because the lesion is limited to a foreventricle, right by in the nodulus, you may not find much unless it causes hydrocephalus or something like that. And so you're left with really the pattern of nystagmus and truncal ataxia to make the diagnosis.
The second question is, thank you for, this is from Giacintino Sperella, thank you for very interesting lecture. Do you consider cupulopathy, light heavy cupula, in the differential diagnosis of persistent positional nystagmus? Any input on that?
There the nystagmus is geotropic, right? That's one of the big difference. And they will not have the downbeat nystagmus either with positional testing.
Yeah. And I mean, a lot of times what I go after is, of course, habituability is one thing, but the other central lesions, right? I mean, it's too good to have like a central positional nystagmus with just having nystagmus and not having anything else causing cerebellar deficits. So that helps a lot to differentiate central with the peripheral.